Well, tonight's week 9. What we're going to talk about tonight is it's going to be pretty confusing because it's health and disability and long-term care insurance. The disability and the long-term care insurance, that stuff's not going to change. But as you know, if you pay attention to the news at all, healthcare is in a huge state of flux. And anyway, who knows what exactly is going to happen. I can tell you the one thing is that we are probably not going to have anything close to the system that currently is being proposed without a lot of modifications, just because. Um, we'll talk a little bit more about that as we go through, but we'll try and stick to the objectives, and I'll try and you know my goal is not to um, be political or try and indoctrinate anybody, but some of the issues. Um, hmm, for some reason, I can't hear you on my laptop. I don't have this problem in any of my other classes, though. Can everybody hear me all right? Yep, I think we're doing all right. If not, I'll switch microphones. Yep, Melissa's got me. Anyway, these are the objectives. So, explain the cost of healthcare insurance, why they've been increasing. And we'll hit on a couple things that the book really doesn't touch on. Define health insurance and disability income, analyze the benefits, evaluate private sources, praise the sources of government health care programs, and recognize the need for disability income insurance. So those are all fairly important topics. The cost of healthcare insurance. Nobody likes the current system, and yeah, maybe there's some free market type things that can be applied in terms of competition amongst the states and different sort of plans. But uh, sometimes the solution that they're proposing is well, evidently it seems to be a little bit more causing a few more problems than people had perceived. I think anybody had perceived. So, but the costs in the U.S. are huge, and twice as much spent on healthcare as the average of the 24 industrialized um, nations. You can't argue with those statistics, but what you can argue with is the amount of contributions disproportionate that come out of the U.S. healthcare system. A lot of the medical advances and other things, and when there's a crisis in Africa or some new disease that pops up, it is usually um, you know U.S. firms that are involved, U.S. professionals that are involved. So that might be a little bit of an explanation, but and I'm not arguing that the current system is not completely uh, pretty inefficient. But again, what's it going to be replaced with? Medical expenditures, 6% of GDP now, but that was in 65, rose to 13.6. So things are out of control. Um, Expected to continue growing 20% for the next 6 years. And then the admin costs, as compared to Canada. Canada, as you know, has got a single payer type system where the government's totally in control. And that may be one of the options. Again, I that would have its own unique problems, and there's many Canadians that travel to the U.S. for healthcare, so it's not exactly nirvana up in or down in Canada. Um, so the book does talk about some of the things, and I'm not trying to politicize it, but I did kind of underline, put in red, believe there because it was supposed to reduce long-term growth of healthcare costs, protect families from bankruptcy, guarantee a choice of doctors. That's already gone. Invest in prevention and wellness, patient safety, quality of care, affordable care, and maintain coverage, losing or changing jobs, and the pre-existing medical conditions. There's a lot of factors that we'll talk about that are good for society. There are certain things. If somebody has a serious medical condition, um, um, that's something that is not necessarily insurance. Society, does have an obligation to take care of folks, but that's not necessarily insurance. And again, I don't want to politicize this, but I can tell you why that long-term growth of healthcare costs that can't be done. It's incompatible with what they're talking about in terms of pre-existing medical conditions, because you can't insure a pre-existing medical condition. Um, you may pay for it through a government program, but to call it insurance is kind of a game in words. I mean, for example, let's say you have a car that you want to get auto insurance, and you have the tow truck drag it up in front of the insurance company, and the car is totaled out, and you say, yeah, I want to get insurance. I mean, that's not insurance. You can say, yeah, it's totaled out, it's got a pre-existing condition, but that would not, that's not insurance. Same thing with a house. If you try to insure a house and they ask you how many square feet it is, you say, well, yeah, it burned down a few weeks ago, but I want to get insurance for it now. Again, that's not something. So if you try and lump, people with serious medical conditions into an insurance policy, then you're gonna basically skew the rates and everything else in that program, because you're not insuring a potential act that might happen. You're insuring something that's actually going to happen, and by definition, that's not insurance. So the government has some sort of obligation to take care of that. There needs to be a different program for that, but to have a self-sustaining insurance program with those sorts of situations, that's just not plausible. Why does healthcare cost so much? Sophisticated medical technology, of course. If your child is ill, or if you're ill, you want the best available. So yeah, are we going to cost a little bit more? And believe me, even in the countries that are definitely first world. What happened, Melissa? Melissa's got a question. Go ahead. Okay, no question. Anyway, so duplication of tests and technologies. Well, we're a pretty litigious society. People will sue each other now and then, quite often actually, and so there is some duplication. That's another issue that is separate from insurance, but it does cause the rates in the United States to be quite a bit higher. Increases in variety of frequency of treatments. Yeah, some people do tend to go to the hospital for cold, flu, other things that might be treated at home in other societies. So again, I'm not trying to badmouth the U.S. system, but I am saying that these things are going to lead to greater healthcare costs, especially the more elderly people, the increase in longevity, and then the regulations with cost shifting. But again, the argument for that may not be more regulation. But anyway, my big picture is, regardless of whether you're a big supporter of the current healthcare plan that's being proposed, I don't think it's going to be enacted in its current form, because there's really no supporters for it. Clearly, you have one political party, the Republicans, who don't want any part of it, and then you have the Democrat Party that really would rather have single payer. So there's not really a champion who wants to make this current system work. So again, not to editorialize, but it's probably going to change drastically, and that could be for the good. Other reasons why it costs so much: increase in crimes, accidents. Well, we don't live in Chicago, so we don't necessarily have to worry about that much violent crime, but it's I'm not sure that statistically year to year that's increased that much. The limited competition, that does happen. Doctors, doctors, if you go to school for that many years and pay those kind of bills, and yeah, they expect to be rewarded to a certain extent. So innovative treatments, again, it's like the technology. We certainly don't want to turn our back on that. And built-in inflation, sometimes those index charges, the increases, that does happen. Malpractice insurance, again, not necessarily a health insurance problem, but a symptom of a bigger problem. And then the aging baby boomers, which we already discussed. So what's being done? Again, this is a list of careful review of fees and charges. Again, that's what causes doctors to leave the network. So if you look at the number of doctors that are willing to to work for those lesser fees, that's going to have an impact. Preventive care, always a good thing. Services provided out of the hospital, exactly where you can do more, get more health care with less cost by not having everything require hospitalization. And prepaid group practices, again, usually a win-win. And community balancing. All these things are good proposals, but none of them are going to drastically lower the healthcare cost based upon some of the key things like primarily the growing number of people in the older segment of the population that require more healthcare, and that requires more young people to pay a disproportionate amount to basically subsidize them. So anyway, that situation's not changing. All these flexible spending accounts, that whole thing is changing now with the new healthcare laws. High deductible health plans, most people are going to end up with high deductible plans. I mean, most people are kind of getting a shock here when they look at the bronze plan, which is supposed to be the lower cost plan, but a $6,000 deductible is that's pretty high deductible, $6,000 per year, and this is for lower income folks. Not too many folks with $6,000 laying around per year. Expensive generic drugs, that's probably forced upon us most of the time. Most people don't opt for the brand name drugs. So again, a lot of these things are not that much of a change. The low cost for uninsured children, we have Denali Kid Care up here if you're at the poverty level, and that can be helpful. But again, most of you probably will not find yourself in that situation once you finish school. So, what to do to reduce your personal health care costs? Obviously, all of these items are going to be good plans. It's a curious situation that some of the prescription drugs now are really quite inexpensive without any assistance. Even my dog, when I go to Walmart, he's under whatever. He shows up as a canine with the name of Bosco, but he pays $4 a month for his prescription. So some of the generic pills really are not that expensive. Now, if you get into any sort of specialty or any sort of new emerging drugs, yeah, that gets out of control in a hurry, and there are programs for that. But obviously the fraud, waste kind of stuff, the errors in the billing statements, the unfair decisions, you need to be on top of that. Other ways to reduce it, again, this is personal finance, but we all know that how you live affects your propensity to be involved in serious health issues. So again, I'm not going to pretend to be your nanny here, but you do have an impact on what your health situation is going to be later in life by how you live it now. The health insurance and disability income, explain their importance in financial planning. Again, some of the statements they have in here are, well, they're living in sort of a nirvana. In fact, under the current plan that's being proposed, if it does go into effect, by 2020 there will be 40 million uninsured Americans. So this plan is not necessarily taking care of that. This other part about the older student population, with the new laws, you're good. Age 25 under your parents' policy. After that, you can buy a policy, under one of the exchanges. Now the situation would be that, again, it's kind of a goodwill gesture on your part to buy insurance because most folks are pretty healthy, and what in essence you'll be doing is subsidizing some of the older folks, because there's limits on the amount the older folks can pay in comparison to younger folks. For most younger folks, what they're going to find, at least for the first couple of years, is go uninsured and pay the $95 penalty or the percentage of your income. So it's kind of a mess. the real people to lose out are the old commercial insurance companies, because a lot of people are going to be going uninsured and just paying the penalty and showing up and again showing up with a pre-existing condition at the emergency room and taking the insurance at that point. So it's a tough problem we've got. Health insurance limits the financial burdens people suffer due to injuries or injury. That's true. It's part of your overall risk management. And then disability income. Okay, disability income, that's going to be one of the things we can talk about tonight that's not going to change too much. Disability income, what that has to do with is if you're hurt and you can no longer work. Now again, there's some abuse in that system. There's different types of disability income insurance. There's government provided type stuff through Social Security, and then there's also private insurance. The problem with the government provided system is currently it's under quite a bit of abuse. Their welfare payments are state payments, and what states have been encouraged to do, in fact they pay an incentive to companies like Bender and some of these other lawyers, is to get some of their long-term welfare people and put them under disability, and that is a federal program which relieves the states of paying that money. So you can probably expect some disability changes to occur in order to get the costs under control, because that situation, at least the federally funded disability, is currently out of control. Group health insurance plans, yeah, 90% of all health insurance. But again, this whole thing is going to change. We're either going to end up with a more or less more of a private free market system in response to Obamacare if it went away, or we're going to end up with single payer, which there are no private insurance companies. So we'll see what happens in this whole thing. But it's a huge deal. It is 1/6 of our economy is tied up in healthcare. So any changes made to that are going to drastically affect things. And all the computer problems are not helping. They are already talking that this mandatory requirement for insurance is probably going to be delayed. It's already been delayed for corporations, and it's just whether it'll be delayed for individuals. But at this point, how can they require people to sign up for something that they can't sign up for? So anyway, not to politicize it, but expect huge changes to happen. The employer-sponsored plans, those are almost becoming legacy type things, unless you're working for, I still have a program under the university, as a lot of folks do, but in the private sector, companies are choosing to let you either go on the exchanges or self-insure. So this group plans are becoming less and less prevalent. The 1996, the Portability Type Act, and there was also a thing going back to the Reagan years, back in '84, a thing called COBRA. And you'll hear people talk about COBRA and portability. There's different acts that have tried to put some federal regulation in there to prevent people from becoming uninsured when they're in a transitional state. So there's certain acts that will prevent that. Again, some of these things will go away if we all end up under one single plan. Anytime you have a group policy, yeah, you can supplement it. You obviously can't be making money. The policy are limited 100% of allowable medical expenses. So if you're overinsured, don't expect to be getting a windfall. Those companies will only pay up to the limit of the medical expenses and no more. This was the COBRA thing that we were talking about. COBRA it's a cool name, but it doesn't really. It was actually the Consolidated Omnibus Budget Reconciliation Act. So it has nothing to do in the title in terms of medical care. But what it did do was it did things for like divorce or people in transition between jobs, and again, it had to do with portability. The aspects of the stimulus package, those are largely expired. And that was just to help people in the transition because a lot of folks were being laid off in what they thought was going to be a temporary situation. So, basic insurance plan, what it should have. Again, with the new healthcare plans that are being proposed, you no longer have the option of saying, you know what, I just want a bare bones, high deductible plan. All plans now have to have certain features. And so these lifetime caps, going away. A lot of these other expenses are going away. Now the deductibles are not. When it says limit your out-of-pocket expenses to no more than $3,000 to $5,000, no, it's a $6,000 deductible for medical care and a $6,000 deductible for prescription costs. So go figure. The plan, like I say, in its current form right now is not really worth getting too spun up about because I believe as they put it forward, it's going to be deemed unworkable and it's going to transition to something else. Types of medical coverage. Again, as we move to something else, these may be more legacy terms, but there used to be provisions where you could just sort of pick and choose, do sort of a cafeteria type selection, and pick the items that you wanted to be insured for. So you could still do this if you wanted to pay the penalty. You could be self-insured, and you could go to private doctors, and since they would not have the same bureaucratic system to deal with it in terms of getting payment or partial payments and the rest of that, on a cash basis, you could contract for these things. In Europe, it's pretty common. I know in traveling in Eastern Europe, especially, there's a lot of dental care that's done down in Latvia, in Lithuania, for example, and other people. Brits will take vacations and go get medical things done. People from the United States will go to Costa Rica and get things done and basically pay for the vacation. So really strange adaptations can happen with when people want to privately pay for their medical cares. Also, they had another program that just paid for the physician. But again, when you start to pick and choose some of these cafeteria things, it can get a bit dangerous if you pay for the physician, but then you get a bill for these other charges that can get quite high. So be careful if you're going to individually choose options. But this was up until recently one of the options you can do before there were mandatory coverage items. Major medical expense insurance. This was what people, in most of your age category used to do. They would go for some catastrophic type medical insurance, and for everything else, you would just go to a little Mediclinic or something else. But if you were, found to have some serious medical problem, you had a catastrophic care, and this is different than a pre-existing condition. You didn't know you had this, so it is truly a type of insurance. When you bought the policy, it was sort of like a car. You weren't expecting to get in an accident, but you wanted to be covered in case something bad happened. So in this type of situation, these policies work pretty well because you get 1 million people insured, and there's going to be a few folks who really are going to be expensive for the plan, and the rest are not, which is a totally different situation than having people that have a existing problem and anyway, it's a tough situation society will have to deal with, but for those people with those types of situations, with a serious medical condition, there'll have to be a separate program outside of an insurance scheme to deal with that. Other things, comprehensive major medical insurance. This is what probably a lot of us grew up with, where there was a simple copay or something like that, and you went and things were taken care of, and this used to be more or less doable before medical costs got to be so high. Now, in order to give you that low deductible, your actually monthly rate would be incredibly high. This dread disease cancer insurance policy, yeah, just like they say, this is different than catastrophic care because this has got certain listed conditions that they'll pay for, and yeah, often sold by salesmen working on commissions, poor value. So anytime you've got a real high pressure salesman, I would, the hairs on the back of your neck should stand up a little bit. There's probably something about this that is not such a good deal for you. So, other types of care they had, hospital indemnity still happens. That just pays for the hospital stay. Now these other things, dental and vision care, those are going to be separate from medical insurance, and still can be a pretty good value. So, again, those, if you work for a company with a traditional HR package, there's usually some dental or vision care, and they're in the $20 a month kind of range. So those are fairly good value, and dental expenses and obviously optometrists and those things don't seem to have had the same level of increases. Plus, you don't often hear of at least I've never heard of as much malpractice going on in either of these two areas. So if the lawyers aren't getting a big chunk of the money, then that's going to reduce the cost for everybody involved. Long-term care insurance. This has to do with the aging population. Again, people end up in rest homes or other type things in some sort of nursing home. And yeah, you look at the figure there, 72,000, which depending on the area, that can probably vary widely. But you look at the premiums, 1,000 to 16,000 per year. So, obviously, if you invested $1,000 a year, yeah, you're not going to cover that with a conventional investment. But if you're putting away 16,000 per year, you would have a pretty good stack of money to basically self-insure. So different options, but again, it's something people are being faced with, is people are spending so many post-employment years in sort of retired status, and then if they end up in a nursing home status, hopefully most of us will not end up in that situation, but odds are that's a reality. Major provision in a health insurance policy. So eligibility, obviously, well, the eligibility factor is actually going to go away. Now, this is going to be a factor in terms of calculating your rate, but if it's a mandatory policy, by definition, you are eligible. This is assigned benefits. Insurance pays your doctor or hospital directly. That's usually the standard anymore. And then the internal limits. The limits now are, what's happening is the amounts being paid to the providers, the hospitals in general, are being decreased to the point where a lot of those providers are not going to be part of the network. And if you go out of the network, none of your costs are going to be reimbursed. So there's a lot of turmoil right now, and rather than spool up a bunch of fear and discontent, we just need to let it go for 6 months to a year and see what shakes out of this current situation. Co-payment. A lot of us are familiar with this, though. It's usually sort of a trivial amount. I guess it's just to prevent the nuisance of people running to the doctor for everything. But $15 to $20, $30, I don't think you're really going to people are probably still going to go because that's a pretty trivial amount for most people. Um, Service benefits versus fixed amount. Again, this has to do with the reimbursement that's being provided, and a lot of times you'll see amounts on the bill that seem astronomical, but when you look at what the Medicare, Medicaid reimbursement is, there's a reason why they set it at such a high level because they're only going to get a certain percentage of that. So uh, they're their own worst enemy in terms of the system. Types of healthcare coverage continued. So benefits limits. Again, a lot of these limits are going to be going away. So that's a good thing, but it also, again, we start getting away from insurance, or we start getting into sort of a one size fits all type policy. And for the person who just wants the catastrophic coverage, he's no longer going to be able to find that, and will either pay the penalty or pay a pretty high rate. So we'll see what happens. Another thing about these rates, a lot of times they're subsidized, but they're subsidized um, from your taxes. And if you're somebody who's not paying much in the way of taxes, you'll never get the subsidy. Or you would have to wait till the following April to get your refund, and a lot of folks can't foot the bill for that. So we'll see what happens, but a lot of issues. Health insurance trade-offs, reimbursement versus indemnity. So, out of pocket versus the hospital being paid directly. Internal limits versus aggregate limits, and deductibles and co-insurance. So, again, the way they structure the system can have great effect on you. How much you're going to have to come up with, and out of pocket. The co-insurance business is a lot of times if you have two plans, obviously both plans want to talk to each other because they want to make sure that you aren't being paid twice, that only the amount of the coverage is paid, and usually it won't even cover the deductible even if you have two competing plans, but they both have to know about each other. If you have a system like, say, TRICARE, the government is always the secondary payer, so they'll take the private insurance to the full amount, and then the government will pay the second. So again, makes it tough for the private insurance companies. Out-of-pocket limit or stop loss. Again, when you start to hit limits, like I say, I'm not an advocate for the current system, but it has caused people to go bankrupt, and it will continue to cause people to go bankrupt. So we'll see. I would say that with a $6,000 deductible, $6,000 for most folks is fairly catastrophic. Anyway, benefits based on reasonable and customary charges, which is true. And again, the reimbursement amounts can make it to the point where certain doctors will just sort of check out of that network, and they'll only accept private customers. You can get everything online, just like shopping for auto insurance. You can shop for healthcare insurance, except on the government site. All right. Evaluate private sources of health insurance. We'll see what happens with this. Blue Cross Blue Shield, they were proponents of the mandatory insurance because they thought they would be getting more customers. Well, we know in certain states there's, you can count in certain states there's actually no customers being signed up. So we'll see what happens. But I think there's definitely going to be a shrinking in the private insurance market, and Blue Cross and Blue Shield are going to be radically different from their current vision right now. The managed care, you can do the prepaid systems in a primary care physician. And again, people who opt to some of these doctors that are going to be out of network, they'll be just taking private physicians. So the people who are going to be least affected by this are going to be the very wealthy. The people who are going to be most affected are going to be the people who the program was designed to help. And anyway, that's not the way it was intended, I'm sure. HMOs, health maintenance organizations. Again, this is going to kind of mirror what we're going to have if you're under the government system, where there's just going to be certain providers, the prepaid monthly and prevention wellness. They're gonna certainly at least talk about that, and basic and supplemental services. A lot of that is now mandatory. So mammograms, things like that, are all going to be part of that program. Preferred providers, the PPOs. Yeah, again, this whole system is going to change radically, and nobody knows exactly what we're going to end up with. The home health care agencies, that's mainly like the elder care type stuff. We'll have to see how they're affected right now. You know, it's going to all change. It's really going to be a shakeup of it. The employer self-funded healthcare plans. Most of these folks are turning people away, or at least turning away the dependents at this point. Labor unions are in a tough bind because one of the big benefits that they've offered their members was the fact that they had good medical systems. So, but the problem is now if their systems are too good, then they're considered Cadillac plans, and there's a penalty. If they're not good enough, well, that's usually not the case. But it's usually makes economic sense for them to turn their members over to the exchange market. But then the members go, wait a minute, why am I in this union to begin with? So lots of issues. But the trend for employer-funded programs is definitely going away, and you're going to see that probably phasing out as things continue. All the spending accounts, there's certain income limits on those, and health savings accounts. A lot of folks will not qualify, or there's new limitations being placed on them. And again, there's really not an aspect of healthcare that's not going to be changed by the provisions that will be happening in the next 6 months. Okay, Medicare, which is different than the what they're calling Obamacare. This is for the very old folks, or older, 65. This is going to have some changes. They've already taken some money to pay for the other parts of the other programs, so there's going to be some reductions, but they've always had the Part A, which was the hospital, the B was the medical, and then the D, which was kind of controversial because that was the prescription drug benefit, and then C was the, when we start talking about donut holes and all that stuff, I'll confuse you. But anyway, Medicare is still out there, which is different than Medicaid. Medicaid is the low-income version. So these are the people who are below the limits for what they're calling Obamacare. Medigap pay what Medicare doesn't. So there's different systems in there. If you're eligible for them, you would know it, but most of you who are going to be embarking on careers will not be involved in Medicaid and Medicare not till some point later in life. Most of you, though, it'll be means tested, and you probably will not be part of that program. Medicare fraud, obviously they've got some programs to try and cut down on it, but as with any large program, there's bad people out there, and there are incentives if you can identify them. Again, the authors, they're talking about the money that's been set aside for reform, the tax credits for small business. It's a lot of this is prohibiting denying coverage based upon pre-existing medical conditions for children. Again, that's not necessarily an insurance plan. That's more of a general plan that needs to be covered by a different system, more than likely. Affordable insurance for well people, people without any medical conditions. Again, some of the deductibles, $6,000. It's and premiums that are over $1,000 a month for some folks. You could argue whether that's affordable or not. Um, yeah, and I'm not saying the insurance companies were without fault. They may have dropped some folks when they were sick, but again, those problems should have been addressed. Co-payments for preventive services. Yeah, if the insurance companies are smart, the actuaries will tell them that that's not a smart process. If you can get somebody a mammogram or something like that to prevent a catastrophic problem later on, that's money well spent. So, and the 26 to remain on, defining children is up to age 26, which again, not something the private insurance companies would have opted for, but that's now part of the program. Key provisions, lifetime caps eliminated, annual limits. Well, a lot of these things are, I'm not going to necessarily read through them because they're, anyway, it's just more controversial what's going to happen here. And the websites, oh boy, give those a go. Recognize the need for disability income insurance. Okay, finally something we can talk about that's not controversial. Okay, disability, let's say, you're, whatever, fall, do something at home or at work, and your ability to earn an income is going to be drastically reduced. So, and your income or your expenses can likely go up. Maybe not, but in any case, you're gonna need to have some sort of coverage to make up for that loss of income, and it's going to be a long-term situation in most cases. So what we're talking about now is largely private insurance. Can only pay if you can't work at any job. This is kind of being stretched to the limits now. We got a lot of folks, that are obese, bad backs, things like that, that probably can do a few jobs, but anyway, long-term disability. So that's more of a issue that's going to need to be taken care of here in the next couple of years. So you can expect some reform on that. But what's happened is the drop in the welfare rolls. The state-provided welfare has dropped a fair amount, but the disability the federal benefit has exploded, so something will have to be done with that. If you're looking at any sort of plan, though, for a private type plan, something about 60 to 70% of your gross pay is what you're looking at. So, I would argue that, let's say I would think your expenses would go down a certain extent, in terms of commuting to your work and all those other expenses would be decreased slightly. It does cost something to show up at work each day, but anyway, benefits last. Yeah, it can be either to age 65 or for your entire life. The waiting period, how long till it takes effect, and then obviously you don't want something that's cancelable, and you want to be able to renew it. So again, deal with reputable companies. Stay away from high-pressure salesmen, and you should be fine. Again, it's not the traditional, or it's becoming more of a legacy, but companies do offer this, and it's something that especially if it's subsidized by your employer, you'd probably want to jump at it. The relying on Social Security is, again, there's so much extra friction on that system and extra drag due to abuse and it not really being in a lockbox like they say, that system is going to be bankrupt unless it's massively restructured. So the employer policy through a private insurance is probably more of an insurance policy than putting yourself at the mercy of strictly Social Security. That can make for kind of an unpleasant situation. Workman's compensation, that has to deal with if the injury happens at work. So 70-80% of your take-home pay. So again, this could make the difference between a pretty dismal life and being able to get by and have your family get by. So what you're just trying to cover is the situation, where your income is going to be non-existent because you're unable to work. So hopefully, though, you can, we've all seen students here at UA especially who have some, you know, situations that, where they could simply check out and not be productive members of society, but they do, and they prevail, and I think they're far happier, and I think that's the better way to go. So anyway, I'm not going to preach, but again, if you can work, I think you'd certainly have a more prosperous and enjoyable life if you can find some sort of adaptive way to continue. Anyway, I haven't spoken much about the test. Nothing but issues with that, with the whole Collaborate, well, not Collaborate, but the Blackboard system. I've had to delay giving out the results to everybody in terms of the actual questions because I still have people taking the tests. So until that situation is resolved, I expect to get that done. Wednesday night was this Wednesday night is going to be the last time for folks to turn in the test, and that had to do with a few folks that either were midway through the test and the system crashed or weren't able to get on the system. So we've got some folks taking this class who are even in different countries and things. So I have to be fairly flexible, and especially when Blackboard's not helping us out. So I appreciate your patience on that. And yeah, Christine's got a good point about make sure you report injuries at work immediately. Not only does that protect you, but it also protects the employer. The employer, if, I'm not saying you want to fudge things here, but if something bad happens to you, it behooves you to make that attributable to work if that's the nature of the situation. And, these can be different issues. I have a friend, she's a barista type thing, doing the making espresso, and her wrist is completely unworkable. That's a work-related injury in my mind. Obviously, things like falling off a ladder and a direct injury, that's something that's easily attributable. But some of these other issues, make sure you report it while you're still in employment with that company, and as soon as possible, and you don't want to artificially generate a hospital visit, but if you've got a problem, you may want to you do want to get it looked at as soon as possible and get things documented in case it flares up later on and there's no question. So anybody else have any comments on anything else? Again, I'm trying to stay out of the political nature of it, but I don't think the Daily Show, I mean, not necessarily conservative folks, and they are going after Obamacare in a huge way now. So I don't think anybody thinks this current system's going to work. Yeah, I didn't report my knee injury within their time frame, and I'm still paying for the surgery. So that can happen. Again, you need to get that documented, and companies a lot of times will, at least a supervisor, they'll be pretty upset if you don't report it to them because they're often accused of trying to duck paying for it. And then there are companies who do duck out on paying for it. So, yeah, if it happens at work, make sure it's attributable to the workplace and then it's documented. So, any more on that? No? Okay. Yeah, again, I'm trying to not politicize this thing, but it's not really a rosy picture out there right now. We've got some issues that were causing some problems with the healthcare systems, but sometimes the fix is worse than the problems. And but I wouldn't lose any sleep over it. At least not for a little while, because I do believe that there's going to be some major changes coming one way or another. And that'll be it for tonight. Anybody got any questions? Well, good night then. Thanks.